Hello friends, welcome back to the channel. So let's go to the third part of Inicet recall discussion. Yes, the question is type 2 lepra reaction is treated by A. Stopping MDT and adding glucocorticoids, or only add glucocorticoids, or cyclophosphamide or thalidomide. Type 2 lepra reaction nothing but this acid fast lepra bacilli. Once treated, what happens is this will be engulfed by some of the antigen presenting cells, which are nothing but macrophages. This can stimulate present this antigen to the T helper cells, T helper 2 cells, and this can stimulate the B cells to produce lots of antibodies, and this lepra antigen and this antibody form antigen antibody complex, which is a type 3 hypersensitivity reaction, and they start depositing in multiple areas of the body. So where and all it can deposit? It can deposit in the skin, anywhere in the skin. So this will form painful, tender, nodular eruptions in the skin, which is called erythema nodosum leprosum. That too in the warmer part of the body, like in the chest, trunk, as well as limbs. So then if you see, patient might also have this immune complex deposits in the uvea, causing uveitis, conjunctivitis, as well as it can deposit in the nose, causing nasal septal perforations, and it can deposit in the joints, arthritis, myositis. It can deposit in the kidney, causing glomerulonephritis. All these are possible, and hepatosplenomegaly and generalized lymphadenopathy is also possible. So all these are due to type 3 hypersensitivity reaction. So any hypersensitivity reaction, we are going to suppress it by giving an anti-inflammatory drug, which is nothing but glucocorticoid. Okay, so for this, if the patient is already has been completed treatment of leprosy, there just adding glucocorticoid is best. And if the patient is on treatment, or while on treatment, if the patient has developed type 2 lepra reaction, add glucocorticoids to the existing leprosy regimen. So just simply adding glucocorticoids will be the perfect answer for this question. Next, in maple syrup urine disease, which of the amino acids can be given? They told like all three amino acids like valine, isoleucine, as well as leucine, all three are branch chain amino acids which are not metabolized properly in maple syrup urine disease. So only exception is methionine. So option is methionine. Next, in cubital fossa, the order of structures arranged from medial to lateral. As we read mnemonic MBBS, meaning from median nerve, then B for brachial artery. Next is the biceps tendon, and next is the superficial part of the radial nerve. So MBBR. Yes, this order you should put. Next, phospholipase C acts via, obviously it is GQ protein pathway. Not used in the treatment of sickle cell anemia. A. Voxelotor, B. L-glutamine, and C. hydroxyurea, and D. bebtelovimab. So if you see these drugs, sickle cell anemia, if you see, what happens actually is there is lots of sickling happening whenever the RBCs are deoxygenated. Okay, in any case of, take exercise as an example, in acidosis or carbon dioxide retention, hypoxia, all these things will make the oxygen curve to shift to the right, and this will cause polymerized RBCs, and this will occlude the main vessels, mainly the splenic vessels, causing autosplenectomy, meaning spleen will be functionally getting reduced in size in these patients. So asplenia develops in these patients. So obviously in the management, first will be vaccinating these individuals against this capsulated organisms, since spleen is not functioning. Spleen is responsible for eliminating these capsulated organisms like Haemophilus influenza, meningococci, as well as pneumococci. So vaccinations first. Next, what to do? Sickle cell anemia. Next, the age-old drug, which is nothing but hydroxyurea. What does it do in sickle cell anemia? It's nothing but it increases the production of hemoglobin F. Okay, so you can see this in this diagram. It stimulates this bone marrow precursor cells to increase the production of hemoglobin F. The gamma globin chains are stimulated in this patient by this hydroxyurea, and this will cause increased fetal hemoglobin. Fetal hemoglobin will shift the oxygen curve, dissociation curve to the left. So oxygen won't be dissociated from the RBCs that easily. So that will prevent sickling from happening. So they have found after giving hydroxyurea, there is reduction in vaso-occlusive crisis, there is a reduction in number of hospitalization, mortality, all those things have been reduced after giving hydroxyurea. So it is the must drug to be given in sickle cell anemia. Next, L-glutamine. Next, voxelotor. This is a new drug, same mechanism only. Like what is the main theme is to prevent the oxygen from dissociating from the hemoglobin so that polymerization doesn't happen, sickling doesn't happen. So a drug has been given, voxelotor, which inhibits this oxygen dissociation from the hemoglobin. Okay, this is the action of voxelotor. This is also used in sickle cell anemia. Next is the drug nothing but crizanlizumab. This is one of the interesting strategy. What they found was, even if sickling happens, when does the RBC completely block that pathway? Only when the platelets also come into the picture and they form blood clots and cause ischemia as well as necrosis. So for the platelets to attract it to the RBCs, first binding molecule will be P-selectin. So what they found was a monoclonal antibody which was directed against P-selectin, which is crizanlizumab. This decreased the incidence of vaso-occlusive crisis, and thus it is useful in sickle cell anemia. So the other option which was given, bebtelovimab, which is nothing but a monoclonal antibody which was used in COVID, okay, recently. NAPQ is involved in which of the following poisoning? It's nothing but paracetamol poisoning. Active form of cyclophosphamide. Actually, cyclophosphamide is a prodrug which will be activated in the liver to form 4-hydroxycyclophosphamide, which will break down into aldophosphamide. This aldophosphamide has two components. One is phosphoramine mustard, which actually has the cytotoxicity. This is why we use cyclophosphamide. This is the key component responsible for the mechanism of action of cyclophosphamide. And it also has the bad acrolein, which is responsible for our hemorrhagic cystitis. Okay, and also it has another component which is nothing but acetaldehyde, which causes SAADH and neurotoxicity. Okay, so the active form will be aldophosphamide. This was the picture given. First lumbrical was marked, the nerve supply was asked, it's nothing but the median nerve. Next is, a patient was having visceromegaly, they have given, splenomegaly, and the patient was having fever. Here, what will you treat this patient with? And RK39 was positive in this patient. So this is nothing but leishmaniasis, visceral leishmaniasis. Treatment is nothing but liposomal amphotericin B. Actually, in India, we use a single dose regimen, just one dose, 10 mg per kg will give liposomal amphotericin B, that's it. This is the treatment in India followed. As well as in Bangladesh and all, they start giving oral drugs also, like oral miltefosine. Okay, that was a breakthrough in treatment of visceral leishmaniasis. As well as they also give paramomycin, which is given for 21 days, miltefosine for 1 month. Okay, and also for post-Kala-Azar dermal leishmaniasis, they will be using sodium stibogluconate or antimony, or same paramomycin as well as miltefosine can also be tried in these patients. Next, a patient who is given like after having a road traffic accident, his GCS is only 3 out of 15 and CT is perfectly normal. The diagnosis is, so diagnosis is nothing but diffuse axonal injury. Length of the blood vessel is doubled and diameter of a blood vessel is also doubled. Here what will happen to the flow inside the blood vessel? As we know, flow is nothing but delta P into pi r power 4 by 8 eta L. So we can tell flow is directly proportional to r power 4 and inversely proportional to L. So I am doubling the diameter, means doubling the radius, and also I am doubling the length. So 2 power 4 by 2 will be cancelled and it will be 8 times. Okay, the flow will be increased. Next question, not used in management of hyperkalemia. Yeah, so hyperkalemia, first what you should be giving the patient with calcium gluconate, 10%, 10 ml over 10 minutes. Why are you giving? Is it going to reduce potassium? No, it is just going to prevent the arrhythmias in the heart by acting as a membrane stabilizers. Okay, next is what are you going to give to reduce potassium? It is insulin dextrose solutions. You're going to give insulin 10 units in 100 ml D25 solutions. So how much potassium will it decrease? It is expected to decrease 0.5 to 1 of milliequivalents of potassium. So next also you are going to nebulize the patient with salbutamol. That is also 10 mg in 4 ml NS we are going to nebulize. That will also reduce by 0.5 to 1 milliequivalents potassium. But the fastest to reduce potassium, if they ask, it is salbutamol nebulizations. Next, if insulin dextrose and salbutamol, if it is combined, then it can reduce the potassium level even to 1.2 to 1.5. Okay, yes. Next thing is, if the patient is having a known case of CKD, you can try with diuretics like potassium wasting diuretics like loop diuretics as well as thiazide diuretics. Next, you can give some potassium binding resins like sodium poly SPS can be given, or new advanced molecule, it's nothing but sodium zirconium silicate. So what does this do is it will absorb the potassium in the gut and it will release sodium as well as proton. Okay, this is the latest drug discovered. Next, or obviously life-threatening condition, hyperkalemia, dialysis is the management of choice. So magnesium sulfate, it is used in refractory hypokalemia. Okay, in potassium wasting nephropathies, this magnesium will plug the potassium channels through which potassium is lost in urine. Okay, so thus it prevents hypokalemia in case of refractory salt waste potassium wasting nephropathies. Next, X-linked dominant diseases, nothing but Rett syndrome. Okay, you should know the disorders, only few disorders are there. X-linked dominant, you should memorize those set. Next, ACTH is used in which of the following syndromes? West syndrome, Knox-Gestalt syndrome, Rolandic epilepsies. So West syndrome is nothing but a triad of the baby having infantile spasms and salam spells. And also in EEG, if you see, it will be chaotic EEG with nothing but hips arrhythmia, and also developmental regression will be there. Mental retardation might be present. It's not a must criteria, but it might be present. So here, if the infantile spasms, you should see whether in the question if tuberous sclerosis is given or not. If tuberous sclerosis is given, then the drug of choice will become vigabatrin. What is the mechanism of action? Vigabatrin. Remember, like gabatrin. GABA, TR for transaminase, IN for inhibitor. GABA transaminase inhibitor. It increases the concentration of GABA in the synapses. Next, if it is not associated with tuberous sclerosis, infantile spasms, then the drug of choice becomes high dose ACTH. If ACTH is not available, then you can go for prednisolone combinations. Okay, next, a 2-year-old child they are given with recurrent bloody stools, and also patient is having eczematous rash, and also thrombocytopenia is be given platelets 20,000 and petechiae is present. So in what you will do to diagnose this condition? So option the right answer is VASP gene sequencing. This is nothing but Wiskott-Aldrich syndrome. What happens here? Actually, this it's a X-linked recessive disorder. What happens here is the gene VASP is responsible for assembly of the actin filaments. It is responsible for movement, migration. Okay, this if it is defective, when the platelets after forming there, it can't migrates into the circulation. So that will contribute to thrombocytopenia and the platelets will be very small. And if you see, you can remember like Viscott Aldrich. So Viscott, W is inverted form of M. So IgM is decreased since it is inverted. And Aldrich, what is rich? IgA is increased here. And also D, next will be E. Okay, IgA as well as IgE are elevated. This IgE elevation will make you understand why eczematous rash or eczema, atopic dermatitis are present in such patients. Next question. In a schizophrenic patient has been started on risperidone. Patient comes to the emergency after having some uprolling of eyeball. So here, what are you going to do to manage this patient? A, stop the antipsychotic, or are you going to give him lorazepam or promethazine or olanzapine? So here if you see what is happening, extrapyramidal symptoms, though it is classically seen with typical antipsychotics, even the second generation, newer generations can have a minimal amount of extrapyramidal symptoms. So this consists of like within hours to days, there will be this is nothing but increase in the tone, dystonias. If it is happening in the eyes, then it's called oculogyric crisis, eye movement crisis. If it is happening in the jaw, then it is locked jaw or trismus. If it is happening in the neck, then it is dystonia. So obviously the drug of choice will be benztropine. Okay, since it is due to cholinergic excess, it is treated by benztropine, or you can also try promethazine. Phenarcan we have. Okay, so promethazine, if the option was given was promethazine, so answer will be promethazine for this question. Next, the OHA, which has the tendency to produce bone fractures in females. Actually, the option answer to this is canagliflozin. Actually, what they found was S-GLUT inhibitors, sodium glucose 2 transporter inhibitors. When they found in the canvas trial, what they found was only in that trial, those patients receiving this canagliflozin developed fractures as well as amputation risk was also increased. But later studies which was done disproved this trial. Okay, but since it is an historic event, they are still documenting this side effect. And S-GLUT inhibitors you must be studying in detail because they are becoming the trending drugs in diabetes as well as in heart failure. They are recommended in the first line agents in diabetes type 2 as well as in heart failure with reduced ejection fraction. And recently, in the latest 2022 guidelines, it has also been incorporated in first line management of heart failure even with preserved ejection fraction. Initially, we were thinking like no drug was there to treat heart failure with preserved ejection fraction, but recent guidelines tell S-GLUT inhibitors can be utilized for this purpose. Okay, they have multitude of mechanisms to demonstrate this effect. Side effects you should be remembering what are these, like it will cause glucosuria due to which they can have excess genital fungal infections, or as this bone fracture risk, amputation risk only according to this canvas trial. Okay, is seen in only in canagliflozin, and it also causes euglycemic ketoacidosis. Okay, yes. Genu of corpus callosum is supplied by anterocerebral artery as well as middle cerebral artery. Okay. Kasowitz law, as we know, as the pregnancies, number of pregnancies increases, the severity of syphilis, congenital syphilis decreases in the newborn. So this is nothing but Kasowitz law. It is used in congenital syphilis. Last question. MHC class 1 captures antigen and binds to activated what cell? MHC1 means it is present in all nucleated cells. Okay, this will provide the our own basic protein. It will provide at the top of the cells to to tell that this is R cell and prevent autoimmune attack against R cells. So this will stimulate, one will stimulate CD8 and 2 will stimulate CD4. You can remember 8 rule. 1 into 8 is 8, 2 into 4 is 8. Okay, the answer is cytotoxic T cells or CD8 positive T cells. Yes, that's it. Thanks for watching.